Dr. Sahitya Bhaskaran. That's the first one. Comparison of accommodation lag in myopia using MEM retinoscopy and open field autorefractometer. Please go ahead.
Good afternoon. I'm Dr. Saitya. So I'll be talking on the comparative assessment of accommodation lag using MEM retinoscopy and open field autorefractor. So accommodation lag has been linked to myopia progression, and a lot of newer treatments mandate accommodation lag to be measured in children with myopia. So the primary objective of this paper is to compare the agreement between MEM retinoscopy and open field autorefractometer to measure accommodation lag. And as a secondary objective, we also wanted to see the prevalence of accommodation lag in simple myopes. So the inclusion criteria was children with simple myopia with a spherical equivalent of less than -6 diopters and astigmatism of less than 1 diopter, age between 5 to 15 years. All of these children were spectacle adapted at least for 4 weeks. Exclusion being high myopia, ocular pathologies, previous surgeries, children on low dose atropine or myopia control lenses, and an astigmatism of over 1 diopter. So we had a larger cohort of 1,575 eyes with simple myopia for whom glasses were prescribed, and accommodation lag was defined as anything over plus 0.75 diopters. Of this cohort, 60 eyes were randomly chosen to assess accommodation with open field refractometer, and all the 1,500 children had accommodation assessed with MEM retinoscopy. The lag was measured at 40 centimeters, and we also did a follow-up at 6 months to see if progression was, there was some difference with accommodation lag and progression. So the mean age was around 12.43 and the spherical equivalent was -2.38 plus or minus 1.23. Of the 1,575, the accommodation lag was seen only in 196 eyes, accounting for 12.44%. And if you look at the myopia, the most of the lag was around -1 to -3 diopters of simple myopes. Risk factors, decreased outdoor activity and use of near gadgets was the most common. And coming to the actual results, so MEM retinoscopy of the 60 eyes identified 25 eyes, 41.67% with lag, whereas the open field autorefractor identified only 13 eyes, 21%, which showed lag. And at 6 months, again, MEM retinoscopy showed 30 eyes, which was a 50% lag, and open field showed in 19 eyes, 31.67. The overall agreement between them was 70% at presentation, 72% at follow-up. However, these eyes that proceeded to show lag after a 6-month follow-up did not show progression of myopia essentially. So the sensitivity at presentation was 40% for the open field autorefractor and at 53% at follow-up. Specificity was 91% at presentation, 90% at follow-up. A positive predictive value of 84.2% and negative predictive value of 65.9. The overall agreement was only 71.7. The open refractometer we saw was picking up lower cases with accommodation lag, whereas with normal accommodation it had good specificity. And now coming to the regression analysis, we saw that for every unit increase in spherical equivalent, the odds of having lag of accommodation were 13% higher, which means the lower the myopia, children had more accommodation lag. So closer to they were to emetropia, or the milder the myope, the odds of having accommodation lag was high. So we looking at this, we wanted to know if what was it in the general population. Then we realized from literature that around 10 to 20% children in this age group, even if they were emetropes, they still had a accommodation lag. So maybe it's not myopia that's causing the accommodation lag, maybe it's there in general population around this percentage only. So MEM retinoscopy clinically still holds to be the standard for measuring accommodation lag. An open field autorefractometer showed only a moderate agreement, but a lower sensitivity. And again, the prevalence of accommodation lag in myopia itself was pretty less, and there was no significant correlation between the lag and the progression in our study. So to conclude, it as a quick screening tool, yes, it works well. But again, MEM retinoscopy and open field were showing only a moderate agreement. So MEM still holds good for accommodation lags. And the prevalence of accommodation was also not very high in myopes. So now the recent protocol mandates that every child be seen of myopia be seen for accommodation. However, looking at these numbers, maybe it is not important to look for every child with accommodation, but if symptoms of asthenopia or something come up, then we can do it on a regular basis. The limitations of this study, We didn't have a control arm to look for accommodation lag. It was only a cohort of simple myopes, and again a larger group of children are required to validate these results. Thank you.
Okay, thank you. Dr. Dadeya, please come. Can we have a chair? Can we have a chair?
आप इधर बैठो.
Let us have at 4 minutes. Let us have a ring so we know. So please do one chair here. So thank you, Dr. Sahitya. That was a nice study. I just want to know, do you have, because you said myopia prevalence of accommodation lag is not so high, we must have a norm also for the, that was not done. Is there any comparison with other studies where normal
No, I'm not writing. Conflict of interest.
We did not have a control arm with emmetropes in this study, but compared to literature where there is a study by Dr. Rizwana, where in South Indian population they have seen, and that reports around 10 to 20% emmetropes having accommodation
but
lag.
here you got about 40, is it?
No ma'am, here lag was 12.4.
12.4. So what is the reason you think after 4 weeks of wearing glasses at the time of presentation?
For binocular vision, at the 4 weeks adaptation was for all children. Accommodation lag itself was not measured on day 1 of giving spectacle, because every child has to be spectacle adapted before binocular vision sets its tone to normal. That is why every child was seen only after 4 weeks. The second ad presentation and the second measure was at 6 months follow-up. We wanted to see if progression of myopia was also corresponding to the lag of accommodation, but there was no significant association between both.
Thank you.
Thank you, ma'am.
Okay, so the next speaker is Dr. Priyadarshini. Are you here? Yeah. Comparison of retinal microcirculation using OCTA in anisometropic amblyopia and anisometropia. You have 5 minutes.
Good afternoon, everyone. I'm presenting comparison of retinal microcirculation alterations using Octa in anisometropic amblyopia and anisometropia. We know amblyopia is unilateral or bilateral reduction in best corrected visual acuity during the years of visual development, which is secondary to abnormal visual stimulation, and it's the most common cause of monocular visual loss in children. Anisometropic amblyopia, it results from the blurred visual input that is caused by hyperopia, astigmatism or myopia with a difference of one diopter between the eyes. And we know Octa, it is non-invasive modality that permits the visualization of microvasculature. Our primary aim was to compare the Octa findings of retinal microvasculature in anisometropic amblyopic eyes with anisometropic eyes. And our secondary aim was to see the Octa findings and compare the amblyopic eyes with their fellow eyes and anisometropic eyes with their fellow eyes. Our primary objective was to quantify these changes, see the changes in the vascular density in anisometropic amblyopic eyes and anisometropic eyes. And our secondary objective was to compare and see if there is any possible association of these retinal microvascular changes in anisometropia and amblyopia. So we included children aged 5 to 18 years of age who were newly diagnosed with unilateral anisometropic amblyopia, whose fellow eye had a BCVA of 6/6, and for anisometropia, children aged 5 to 18 years with anisometropia of minimum of 1.5 diopters of myopia, hypermetropia and astigmatism, whose fellow eye had 6/6 UCVA. And we excluded children less than 5 years and more than 18 years and all the eyes which had any organic pathology. We included total of 62 children, 31 in each group, and after consent from the parents and children over 7 years of age, we did the cycloplegic refraction. Then we assessed both anterior segment and posterior segment. Then we did OCT and OCTA. We obtained 6 into 6 and 3 into 3 slabs. This is the 6 into 6 slab where we get the fovea and the parafoveal microvasculature. This is 3 into 3 slab where we get the FAZ region, that is the area, perimeter and the circularity index. And the statistical analysis was done, and p-value less than 0.05 was taken as statistically significant. These are the results. In amblyopic group, the average age was 11.58, and in anisometropic group it was 15.58. Our parameters, the central macular thickness, and in octa, FAZ in area, FAZ perimeter, circularity index, and the mean vessel density of the superficial plexus in the parafovea. The 4 quadrants, nasal, temporal, superior and inferior, were noted, and we compared that of the amblyopic group to that of anisometropic group. We found that there is no statistically difference between these 2 groups. This is the bar diagram of the same. Then we compared the amblyopic group with their fellow eye. We found that the mean vessel density of the superficial plexus in the parafoveal region in all the quadrants, in the amblyopic group the vascularity was significantly decreased, and compared to their fellow eyes it was statistically significant. Then we compared the anisometropic group with their fellow eye. We found that the mean vessel density of the superficial plexus was significantly reduced in anisometropic group 2 when it was compared with their fellow eye. This is the bar diagram of the same. There are various studies suggesting that there is decreased macular vascular density and increased FAZ region in the amblyopic eyes when compared to their fellow eyes. But there are no studies currently available that compare the octa changes in the amblyopic eye versus the anisometropic eyes. So we concluded that there were no significant octa changes found between amblyopic group and the anisometropic eyes. And the anisometropic eye, when you compare to their healthy fellow eye, showed decreased superficial vessel density, indicating decreased perfusion in anisometropic eyes. And anisometropic amblyopic eye, when compared to their healthy fellow eyes, also showed decreased superficial vessel density values, indicating a possible association between decreased retinal microcirculation and amblyopia. And the quantitative analysis of retinal microcirculation, octa can be used as a reliable indicator. This study also shows that decreased vascular density is not the only cause for amblyopia, as decreased superficial capillary plexus density was noted in anisometropia too. Hence, the other causes for amblyopia needs to be investigated. These were my references. Thank you.
Thank you, Dr. Priyadarshini. So this was done with the software or manual?
Yes, inbuilt software.
Inbuilt
Yes,
software. So there are some studies which say that the thickness and there is no change also.
Yes, ma'am. There are some studies.
You have not done a comparative comparison with the previous studies, have you?
Ma'am, amblyopia versus anisometropia, this is the pilot study.
Okay. Okay. Anything? Okay. Thank you.
Thank you.
Next one.
So please, the next speaker, Dr. Karthika Chandran.
The semi-final marks, after we completed, we will present the second.
Good afternoon, everyone. I'm Dr. Karthika. I'm going to talk today about a review of use of retropupillary fixated iris glow IOL in pediatric population. I have no financial disclosures. Moving forward, whenever I mention iris glow implantation, I mean retropupillary fixation. So in pediatric cataract, the norm is to do a lens aspiration and do in the bag IOL fixation with or without PCC-AV. But in some special cases, for example, like a traumatic cataract where there is an absent bag or absent sulcus, or in cases like Marfan's where there is progressive weakening of zonules, it is not possible to do a in the bag IOL implantation. In such cases, we have few other alternatives. And iris claw IOL implantation, especially retropupillary fixation, is a relatively safe, affordable, and relatively easy to perform procedure which can be used. There are many studies on iris claw IOL implantation in pediatric population, but most of these studies have some lacunae, like small sample. They either have small sample size or a limited follow-up, or they might have included older age group. And most of these studies have assessed mainly visual outcome and complications. So in our study, we have assessed refractive status and prediction error in retropupillary fixated IOL in pediatric age groups, along with indication, visual outcomes, and complications. This is a retrospective study done from 2021 to 24. We have included all cases of retropupillary fixated iris claw IOL in pediatric age group, except those with incomplete data and incomplete follow-up. And we have used XL lens with an A constant of 117. It is a non-vaulted design, and hence we have done PI in all cases, and the power of IOL implanted is calculated by undercorrecting one diopter from a PC IOL power with A constant 118. Sorry, the PPT which is uploaded is different and the pictures have not come. Please excuse me for this. And these are the data collected. Of this, we have mainly measured 3 outcome measures: prediction error, visual outcome, and complications. Prediction error is calculated as observed refraction minus target refraction, where observed refraction is the spherical equivalent at 1 month after suture removal. In cases where the child is less than 7 years, we have done an undercorrection of 7 minus age, and in such cases that will serve as the target refraction. The visual outcome is a BCVA at final follow-up. We have assessed 40 eyes of 25 patients with age ranging from 4 to 18 years and follow-up ranging from 3 to 30 months. We have included cases with comorbidities. Our most common indications were idiopathic ectopia lentis and trauma, accounting to 28% each. Other indications were Marfan's, microspherophakia, and surgical aphakia. The mean prediction error was 1.231 with 22 overcorrections and 16 undercorrections, and there were 32.5% cases who had prediction error of more than 1 diopter. It is to be noted that all patients with corneal scar had a prediction error of more than 1 diopter. Now, 70% of our patients had visual acuity better than 618 at final follow-up. Those which had vision less than 618 had causes which are enumerated here. The most common intraoperative complication was traumatic enclavation, and post-op complications included raised intraocular pressure, disenclavement, pupil ovalization, AC reaction, etc. There were 3 cases of IOL disenclavement. None of them had any preceding history of trauma, but all of them had history of traumatic enclavement during surgery. And the most common post-op complication was raised IOP. There were 9 cases, of which 1 was a steroid responder, and the other 8 patients had transient raise of IOP, which was noted from 1 week to 2 months after surgery. All were managed medically, and it is to be noted that all cases of traumatic enclavement again had raised IOP post-operatively. This is a study by Shoaib et al. In this study, they have assessed the prediction error in iris claw implantation, and they have similar results to us, only that their prediction error is much less, maybe because they had not included trauma cases. And haptic disenclavation was 20% for them as opposed to 7.5% for us. So, though our study has large sample size and we have assessed prediction error, since it is a retrospective design, we might have missed small findings like iris atrophy, pupil ovalization. Also, we wanted to assess how much the lenticular astigmatism by the IOL is contributing to the prediction error, but we couldn't do that because it is a retrospective design. So to conclude, Iris Glow is a safe and effective solution for pediatric cases with insufficient capsular support. And the most common complication was transient rise of intraocular pressure. Disenclavement can be seen in 7.5%. In all cases which have traumatic enclavement during surgery, we should keep them on a lookout for raised intraocular pressure and disenclavement postoperatively. Thank you.
Thank you. Please make a warning for 4 minutes, at least by 5 minutes. It is not coming. It's showing time's up, but we want a signal. 5 minutes. So the next presenter, Dr. Jyoti Matalia, can come and get ready here. So. I want to just ask you, 3 cases had disenclavation.
Yes, ma'am.
That all the 3 were trauma cases.
No, ma'am. They didn't have any history of trauma, but they had traumatic enclavement during the surgery, intraoperatively.
Surgical procedure was traumatic, ma'am.
Surgical procedure was traumatic, you mean?
During the surgery, while enclaving, the enclaving didn't happen in the first attempt.
Is it by single surgeon or multiple?
3 surgeons. Yes.
And what was the maximum astigmatism?
Sorry.
Maximum astigmatism?
Maximum astigmatism. So, since we had included corneal scar patients also,
I am not asking. I am asking what was the maximum astigmatism?
sorry, sir, I didn't get you.
Astigmatism in your series.
Yeah, I have a case with -5 still also, sir.
Okay, so you didn't go by this A constant 117. You took 118 and
118.
then
Reduce
minus.
1, ma'am.
Okay.
No, sir, we have not measured endothelial cell density.
Thank you.
Thank you.
Yes, madam. Yes, Dr. Jyoti Matalia, I think.
Yeah, okay. So good evening, judges and my dear friends. I'm going to talk on myopia control treatment in progressive myopes in Indian pediatric population. No financial disclosures from my side. Now we already know that 50% of our myopes are in South Asia and 50% of the world population is eventually going to be by 2050. It's important therefore to prevent, and these are the various options. But the confusion always remains, what is the best option to use? Why? Because LDA we know, though it is cheap, it has very low compliance, whereas defocus glasses have cost issues. With this in mind, we decided to evaluate in the last 2 years the effects of myopia control treatment. Why? By using the peripheral refraction. So what is this? We basically use the open field autorefractor manually, where besides the central part, we also use in these different 8 fixation targets the exact refraction, which is at temporal, nasal, 20, 30 and superior inferior. And from this difference, which we calculated from the central position, we were able to get the defocus. So we included all cases which had good vision and refraction of 1 to 6, and we also excluded high astigmatism and isometropia. Any ocular pathology was excluded. Out of the 6 to 16 years myopic progression, we divided them into 3 groups, mild, moderate and severe. And those which were considered for progression was if the myopia increased by 0.5 and if the axial length increased more than 0.3 in the first year. The follow-up was checked every 6 monthly for axial length and refraction. Treatment was planned on the basis of defocus. So if there was hyperopic defocus, we gave the glasses options of defocus glasses or ortho K, but if not affording the LDA. If it's myopic defocus, we gave the options of low dose atropine as mentioned, and in non-responders or poor compliant, we gave defocus glasses, and the significant defocus was if it was more than 0.25. But anyway, patients may not take the same one. There was a bit mismatch and we decided to evaluate the same. So of our results, we had 502 myopes, of which equal distribution in males and females, and equal distribution between mild and moderate cases of myopia. Family history was significant in 82% of our cases. So of the total myopes, 502, 435 had progressed, of which 200 received low dose atropine, defocus glasses were in 229, and ortho K was in 6 of our cases. We had combination in 22 of our patients. So let's look at individual things. So low dose atropine was in 200, and those which were having more than 1 year follow-up only were considered, which was 115. And interestingly, we've had only 48% stable, 52 were not stable, and of these 60 cases, 30 received twice. LDA with defocus glasses given in 22 patients and shifted to defocus in 8. Whereas in cases of those with defocus glasses with a follow-up more than 1 year, we had about 78 patients, of which stable was 76, that is 98% were stable. Ortho-K, we had only 3, and of the 3, all were stable. Interestingly, our mean axial length reduced from 0, was significantly reduced in all the 3 groups as mentioned. So in summary, we had LDA, had more than 1 year follow-up in 55 cases. Halt glasses were in 78. And if you see the LDA refraction reduced from minus 0.78 to minus 0.23 with an axial length improvement from 0.38 to minus 0.14. Whereas in case of glasses, it was a drop from 0.93 refraction to 0.14 and axial length from 0.39 to 0.07. So what we already know is that hyperopic peripheral blur is a risk factor for progression, and LD and defocus glasses eventually are equally effective as mentioned here. What this study actually tries to tell us is that the efficacy between the LD and DG is not status in all cases. Like for example, we had only 48% who did well. In fact, if we look at the IATOM study which we did in India, we were having only 22% progression, but our study showed 52, which means there's a variability, compliance is an issue. Whereas in defocus glasses, we got about 98% for those who had more than 1 year follow-up, but yes, we need a longer follow-up. What this sort of study also tells us, therefore, the hyperopic defocus is not the only cause for myopia progression, and both this LD and defocus works in both the cases equally well, whether it's myopic or it's hyperopic. Compliance always going to be an issue. Now, what is the issue about cost? So, the cost of defocus glasses is about 7,500 to 12,500 at any range. But if you take LDA, it costs about 6,000. But is this significant? It is for the patients to decide, not us, for the parents to take a call. I do accept the limitation that we need a longer follow-up. We have to have a larger sample size and a note on the lifestyle modification. But definitely from the study, I would like to say it's the first study that considers peripheral refraction in the Indian pediatric eyes as a way to compare the myopia control treatments. LD and defocus are variable, but definitely need a long-term follow-up. But at least this is one of the few studies where whole defocus glasses are considered on a longer follow-up in pediatric eyes. And we can use as a PR as a guiding tool to decide and give the options to the parents, because eventually they will decide what can be used, but what to start with can be decided on the basis of the peripheral refraction. So thank you very much for a patient listening.
Thank you, Dr. Jyoti Mutalia. I would like to know, did you take into consideration the peripheral defocus and then start optical treatment
Yes,
with
so
the defocus lenses?
Yes, so we decided first peripheral refraction. If there was a hyperopic defocus of more than 0.75, we gave the option of glasses. But yes, it's not that we forced them, because it was not like a randomized. Parents chose to take, and we had more than 75% who chose the glasses. Those who didn't were shifted to LDA. But we also noticed that those who were on LDA and had a hyperopic defocus did not progress. So what I'm trying to say is, irrespective of whether peripheral refraction is hyperopic or not, we were able to get patients who were stable. So at least this gives us a guiding thing, okay, we have done PR, we can offer this because we are able to show that there is a defocus.
Okay, so those who didn't respond to LDA, you switched to?
No, we gave an option, we made it twice.
After 1 year?
Yes, after one, no, not after 1 year, depending on, anytime, every 6 months we evaluated the child. If in 6 months also it had progressed, we definitely give them twice. So we were watching them every 6 months. These with a 1 year follow-up had people who had progressed more than 0.3 millimeters axial length or more than 0.5. So within 6 months also we notice that the patient is progressing. We either make it twice a day or we add defocus glasses. But again, option is left to the parent.
Thank you.
Okay, the next speaker is Dr. Ashwin, who will be speaking on outcomes of cataract surgery in a pediatric myopic population. Dr. Ashwin, over to you.
Good evening, everyone. I'll be speaking about the outcome of cataract surgery in pediatric myopes. As we all know, cataract in the pediatric population is a significant cause of visual mobility after refractive error. It has a myriad of causes, including hereditary, idiopathic, as part of multisystem disorders and metabolic syndromes. While surgically treatable, final visual outcome depends on many factors. Phacoemulsification with IOL implantation with or without primary posterior capsulorhexis and anterior vitrectomy has become the norm. However, outcome depends on the age of intervention. There is a difficulty in IOL power calculation owing to the rapid change in axial length and low scleral rigidity and elasticity of lens capsule, posing challenges to the technique and high chance of postoperative inflammation. Keeping all this in mind, our aim was to analyze the visual outcome and complications in myopic children, specifically those with axial length greater than 24 mm undergoing cataract surgery in the age group of 6 to 12 years. The axial length of 24 mm was chosen because it was 2 standard deviation above what was norm for this age group. It was a retrospective study between January 2013 to February 2023 with the age group of 6 to 12 years and having minimal axial length of 24 millimeter and those having a minimum of 1 year follow-up. The exclusion criteria include all those who had undergone previous ocular surgeries, those having traumatic cataract or developmental anomalies, pre-existing ocular and systemic diseases, or those with incomplete medical records. Data analyzed included age, sex, laterality, axial length, visual acuity pre-op and at 1 year, refraction and the complications. Looking at the results, we had 56 children and with 88 eyes. Males were predominant with 79.5% of the population. Mean age was 8.27 years and the mean axial length was 25.36 millimeter. 26.1% of the population underwent lens aspiration with IOL, while the remaining had PPC and anterior vitrectomy done along with it. The mean IOL power was 13.75, and we found a positive correlation between axial length and IOL power. The mean target refraction was 1.11 diopters. Mean follow-up was 2.64 years. Looking at the mean pre-op visual acuity in logMAR units, it was 0.89 plus or minus 0.45, which improved to 0.35 plus or minus 0.21 at GA and to 0.28 plus or minus 0.24 at 1 year follow-up. Again, categorizing visual acuity with those having greater than 6 by 18 to 6 by 60 and those with less than 6 by 60, we can see that the visual acuity improved significantly compared to pre-op and final VA, with 11.4% having visual acuity greater than 6.8 pre-op, increasing to 93.20% at final follow-up. The spherical equivalent at glass appointment was 4.7 plus or minus 1.10 and at 1 year was 0.12 plus or minus 1.39, owing to a myopic shift of minus 0.35 plus or minus 1.09. However, there was no correlation between axial length and myopic shift, which was significant. The target refraction was 1.19 plus or minus 1.15, the mean value, and the sphere at follow-up at 1 year was 0.75 diopters. Looking at the complications, 3.4% or 3 eyes had glaucoma. One was a case of bilateral cataract and the onset was at 8 years. Both the cases or all the 3 eyes were managed with anti-glaucoma medication, betaxolol. Retinal detachment was seen in one eye. The onset was 3 months after surgery and that eye underwent vitrectomy with buccal banding and silicone oil implantation, and in final check had a visual acuity of 6 by 18. And posterior capsular opacification was noted in 4 eyes. These were 4 eyes of bilateral cataract, one at 8 months and the other at 1 year. All 4 eyes underwent YAG capsulotomy and had good vision post-procedure. Looking at a brief literature review, Chu et al. In 2019 looked at the outcome of cataract surgery in those under the age of 12 years and had a good visual outcome in 58.6% of the population. They noted that longer axial length had a better visual outcome. Al-Sub et al. In 2022 looked at outcome of cataract surgery in 1 to 5 year age group and noted that congenital cataract surgery showed significant IOP spike in follow-up. And Gogate et al. Looked at the outcomes of bilateral congenital and developmental cataract in those under less than 16 years and noted that developmental cataract, use of phacoemulsification, older children and those with better preoperative vision had better long-term outcomes. Balekutru et al. In their study of those with less than 12 years noted that younger age at the time of surgery was an identifiable risk factor for glaucoma, and Agakar et al. In the study of those with under less than 16 years noted that 5.5% risk for RD is estimated for the first 10 years after cataract surgery, increased risk in male, myope and intellectually disabled child. However, none specifically looked at studies with myopic axial length. Our study showed a significant improvement in visual acuity in cases of pediatric cataract with axial length greater than 24 millimeter. The small sample size and the short duration of follow-up was a limitation in our study. However, it still highlights the use of appropriate technology and timely intervention in improving visual functions. These are my references. Thank you.
Okay. Okay, you said you have a pediatric cataract and myopia. What was the average refractive error or myopia you are having in all of your patients?
That was the thing. It was not possible to preoperatively assess the refractive error.
On the basis of the axial length?
Just the axial length.
Yeah.
It was 25.36 was the mean axial length of the population that we studied.
So the mean IOL power was 13.
Yes.
13, yeah.
What was the age group?
6 to 12 years.
6 to 12 years, so all were left with no PPC. All with PC intact?
No,
all of them?
26.1% without PPC and the remaining population had PPC and anterior vitrectomy done.
Okay. The RD, does it have anything to do with whether you did a PPC or not?
The retinal detachment. It happened in the case with the PPC, ma'am.
With the PPC.
Yes, ma'am.
Thank you.
Thank you. So the next presenting is Dr. Arshi Shikhari. She will be presenting on the efficacy of low-dose atropine in delaying progression of myopia in the fast and slow progression.
Good evening all. I'm Dr. Arshi Nazir and today I'll be presenting our research about the efficacy of low-dose atropine, that is atropine 0.01% in delaying myopia progression in fast and slow progressors. So as has been already predicted by Holden et al. That by 2050 about 49% of the world's population will be myopic, out of which 938 million will be high myopes. So this does increase the global burden of myopia, but something else that contributes to it is the progressive nature of myopia. So due to this, researchers have been going on and on about finding something that could combat this problem, and as a result we have come across various modalities, one of which is the use of topical atropine, and atropine has been used in various concentrations, and out of which 0.01% atropine has been found to be the lowest concentration that retains the efficacy and has also an improved safety profile. So despite its prevalence, the exact mechanism of myopia progression as well as the mechanism of LDA remains unknown. Various studies have found that younger age and baseline myopia have shown to affect the rate of myopia progression as well as a response to the treatment. But there are no studies available that may tell us about whether the rate of myopia progression has any influence on the treatment of myopia. On treatment of myopia with low-dose atropine. So hence the need for our study. Ours was a retrospective analysis that was done in Shirov's Charity Eye Hospital, and our subjects included all children below the age of 18 years who had visited our IOPD from September 2018 to December 2023, and were prescribed with low-dose atropine. We had a follow-up of at least 6 months, and myopia was taken as a spherical equivalent of greater than minus 0.50 diopter, and high myopia as a spherical equivalent of greater than 6 diopters. Exclusion criteria were inadequate documentation, previous use of low-dose atropine, non-compliance or discontinuation of treatment, other treatment modalities, and prior intraocular surgeries. So as far as progression went, we divided the patients into two groups: slow progressors with a progression of less than 0.75 diopter per year, and fast progressors who showed a progression of more than 0.75 diopter per year. So the baseline evaluation, we collected data such as the age of the patients. They were divided into 3 groups: the gender, the family history, birth weight, history of any prematurity. We took measurements for height and weight and presence of any strabismus and amblyopia. BCVA was calculated. We did a cycloplegic refraction. We saw the prescribed glass prescription, the axial length, the anterior chamber depth, the lens thickness, central corneal thickness, and the average keratometry. So once we compiled our results, the sample size turned out to be of 83 children, and the mean follow-up period was 1.9 years. The average age was 10.76 years, and the mean baseline myopia was 7.6 plus minus 4 diopters. And about 45% of the 45 patients had high myopia, and the rest were moderate or low myopes. 49% were female and 51% were male, and fast progressors were 49 patients were fast progressors, and 34 patients were slow progressors. So in our results, we could see that all of the slow progressors as well as the fast progressors, they were not very different in means of the other collected parameters. However, the only significant difference was the presence of parental myopia, and in case of fast progressors, either one or both parents had parental myopia. Again, when we compared the results, it was found that in fast progressors, the effect of low-dose atropine was more. It brought the axial length down by 83%, 50% as in fast progressors as compared to 45% in the slow progressors, and the axial length was brought down to by 72% in the fast progressors, and the effect was not much significant in terms of axial length in the slow progressors. And 12 of our patients, they continued to progress despite the use of LDA, and the common factor in all of these 12 patients was the presence of amblyopia, and all of these patients, they were on patch therapy for amblyopia. So the strength of our studies were that it was the first study to compare the results of in larger population, and high myopia was also included in the study. The limitations were that it was a retrospective study. There was a mixed population of high and moderate myopia. Axial length data was present for a fewer patients, and absence of near work and outdoor activity duration, and shorter follow-up period after the LDA therapy. So the conclusion is that parental myopia is a significant risk factor for fast progression. LDA is an effective first-line treatment in fast progressors in bringing down controlling the spherical equivalent as well as the axial length, and the effect is proportionate to the degree of myopia progression, but somewhere a plateau or a stabilization effect is reached, after which it cannot break down the rate of progression in slow as well as fast progressors. So since 14% of the children, they continue to progress rapidly without any explainable cause, so we can say that a combination of lifestyle modifications, optical treatments, as well as pharmacological methods is necessary for control of myopia.
Thank you.
Thank you.
Dr. Arshi. So did you compare between the high myopes also? You said 45 patients were high myopes.
Yes, ma'am.
And you started on LDA.
Yes, ma'am.
So whether the fast progressors belong to them?
Most of the high myopes were slow progressors, contrary to what has been seen in many of the studies. In our study, the difference was not statistically significant, but most of the slow progressors were in the high myopes, and most of the fast progressors fell in the moderate and low myopia.
So what was the possible explanation for you, because it's going against the odds, having such a high myopia and then you're using low dose atropine and then they are very slow progressors? So what did you, what was the explanation for that?
So maybe some
Are there any studies where such a the contradictory to the usual pattern, whether this has been shown in any study where LDA has been used?
No, ma'am, no.
In
In
high
most of the
myopes?
studies,
Only in
although
moderate.
it has not been compared, but
Is there any rationale in using LDA in high myopes? Now you have to look for it. That you have found that it is stabilizing the high myopes. That's
Yes,
what you are coming to, isn't it?
yes, ma'am.
Okay, thank you.
Okay, next speaker is Dr. Shweta Chaurasia.
Good afternoon. There are no financial disclosures. CFM is a rare genetic condition which affects extraocular muscles, and it is caused because of the maldevelopment of third and fourth cranial nerves. And it has three phenotypes. CFM1 is mainly caused by mutation in KIF21A, and CFM3 is caused by TUP3 mutations. So in this study, we aim to prospectively investigate the clinical manifestation, genetic and imaging characteristics of Indian CFM cohort and their management strategies. We also aim to perform phenotypic and genotypic correlation. It was a prospective study done in PGI Chandigarh from October 2018 to October 2024. The included patients were congenital non-progressive restrictive ophthalmoplegia with or without ptosis with post-op follow-up of at least 6 months. Exclusion criteria previously operated patients. All the patients underwent oculomotility and ophthalmic examination. MRI imaging was done. CIS sequences were done to image the cranial nerves. Quasi-coronal MRI orbit was done for the cross-sectional area, and the dynamic orbit in the various gauges were done. Whole genome sequencing was done for the genomic DNA extraction mutational analysis. The exonic regions were sequenced using the Illumina NovaQ platform. The DNA were fragmented and coding regions were selectively identified, and identified variants were annotated and filtered through the Golden Helix platform. Coming to the results and discussion, there were total 18 patients, 8 male and 10 female were identified. There were 6 pedigree, 6 sporadic cases. Average age was 11.25 years. All showed autosomal dominant inheritance patterns with heterozygosity. Anterior and fundus examinations were normal. None of the cooperative patients had binocular vision. CFUM1, there were 15 patients in CFUM1 phenotype. All had ptosis with upgaze palsy with infrarrectal globe position, chin-up posture, and perverted convergence in upgaze and divergence in downgaze. There were 3 patients of CFUM3 phenotypes with either asymmetrical restrictive strabismus or brain malformation. Coming to the imaging findings, all had relatively thin cranial nerves, and there were 2 patients of hypoplastic sixth nerve in CFUM1 phenotype. There was parenchymal atrophy in 1 patient and thin corpus callosum in 1 patient. Muscle attenuation was present in medial rectus and SR-LR complex. You could see the mean value of the medial and superior rectus was much less than the normal population here. And the mean, compared to the mean LR, compared to their own LR, the medial rectus and superior rectus were 23 to 25% thinner than the lateral rectus. Dynamic orbit was done in 5 adult cooperative patients, and synergistic convergence was demonstrated in 3 adult patients, and synergistic divergence and synergistic innervational downshoot was present in 2 patients each. Coming to the genetics, there were 9 patients of KIP21A and 9 patients of TUP3 mutation. KIP21A code for kinesin protein and TUP3 code for microtubulin protein. And kinesin dimer attaches and moves along the microtubules, and this is important for the human nervous system development. So in the 15 CME of CFUM1 phenotype, generally it is caused by KIP21A mutation, but in our population, there was 60% involvement of KIP21A and 40% of TUP3 involvement. Whereas in the case of CFUM3 phenotype, there were only TUP3 mutation was present. This is because of the phenotypic overlap between the CFUM, TUB and KIP21A, which suggests a shared disease mechanism underlying the 2 disorders. This is the table of KIP21A. So there were 6 patients of missense variant mutations, and there were 2 patients of deletions and 1 patient of duplication. The C2821 was the most common mutation in our series, and comparing the literature, we didn't find this mutation anywhere in the literature. This is the C2821. You could see there is a synergistic convergence in the up gaze and divergence in down gaze, and there was adduction deficit along with the synergistic and innervational downshoot. In the MRI finding, there were thin corpus callosum, there was diffusely thin 3rd and 6th nerve, and there was superior rectus and medial rectus thinning was there. And there was a Y-shaped muscle, accessory muscle at the posterior orbit. This is the C2821 patient showing left eye adduction deficit and innervational downshoot, and you could see in the left side the medial rectus is thin. In the TUP3 mutation, this is the exhaustive table. We had 6 patients of missense mutations and 2 patients of deletions. This is the TUP3 C211 patient showing this is the right gaze, and this is the down is the left gaze, and you could see there is a synergistic innervational downshoot. You can see this is the inferior rectus, which is in the right gaze, and the same inferior rectus has increased in bulk in the left gaze, showing in a synergistic innervational downshoot. Coming to the management, bilateral supramaximal recession of IR and LR was done in 10 patients, and LR periosteal fixation was done in 2 patients. Bilateral superior oblique weakening was done in 4 patients, and inferior rectus to medial rectus transposition was done in 2 patients. These are some of the photographs of the patients after inferior rectus recession and LR recession. This is another patient. This is again the photograph of another patient after IR recession and LR recession. This is another patient. This is the patient of sole KIF21A duplication, in which there is only adduction deficit in the left eye along with the synergistic innervational downshoot, and inferior rectus to medial rectus transposition was done with a good surgical outcome, and we have already described this synergistic innervational downshoot in our previous paper. So the take-home points are the KIF21A and TUP3 are both can constitute the CFUM phenotype in our Indian cohort, and C2821 was the most common novel KIF21A mutation in Indian cohort. Compared to the literature, the sixth nerve could also be involved, which we have seen in the previous literature also. Brain parenchyma atrophy can be present, and MRI imaging is crucial in identifying the structural abnormalities of CFUM. The limitation of the study, though we had 18 patients, but still it's a small cohort, advanced imaging is required and further genetic workup is required. Coming to the conclusion, genetic analysis is critical for diagnosis and understanding. Imaging is essential for assessing the structural abnormalities, and titrated surgical therapy is important depending on the FDT and misinnervation, and the future research is required to expand cohorts and advanced imaging. Thank you.
Thank you. So did you find any correlation with the genotype, phenotype, so that you can put into after clinical examination? After clinical examination, you can say this may be KIF or the tub one.
Yeah. This is the, I think it's not, we have done the phenotyping and genotypic correlation, and we have seen that in C2821 population, we had two pedigree, 4 patients of family who had misinnervation, synergistic convergence, they had synergistic divergence, they had synergistic innervational downshoot, they had, but the sporadic didn't had the misinnervation. So this was the correlation of genotypic and phenotypic. Moreover, we have got all the patients with CFUM one phenotype. But we found in the literature it is available that KIF21A gene is mainly responsible for one phenotype and TUB3 is for 3. But in our population, 60% of the population were KIF21A and only 40% and also 40% were TUB3 in one phenotype. So this was, yes, just solely by the one phenotype that it will be KIF21A only and not TUB3.
Okay, thank you. Dr. Satyan Deka. Dr. Satyan or Dr. Nilupal Bora. Dr. Satyan. Oh, okay. Next is Dr. Amrita Sahani.
Go anywhere. जहाँ मर्जी.
Can you please upload the corrected presentation? This was the old one. It will be by the name of Amrita Sahani. Sorry, judges. I think this is
the MEK inhibitors, revolutionary for treating orbital neurofibromatosis NF1 in children.
my name. It's with my name. It's not this one.
Do you want to check it so that we can ask the next speaker? Yeah, go ahead then. Is it there?
Good afternoon, everyone. I will be talking about the use of MEK inhibitors in treating orbital neurofibromatosis in children. I have no financial interest. It's not moving. Yeah, I have no financial interest. So a 19-month-old male child presented to us with right eye protrusion since the age of 2 months and was also unable to close the eyes. There was no other significant history. Systemic examination showed multiple caphylod spots on the back, abdomen, and the trunk.
Ocular examination showed right eye pulsatile proptosis, and the child resisted the occlusion of the left eye, which signified low vision in the right eye. On retinoscopy, we noted significant refractive error on the right, intraocular pressures were raised, and there was a discrepancy in the cup is to disc ratio. The imaging showed sphenoid wing dysplasia with proptosis on the right, that was on NCCT orbits, and the MRI showed diffuse orbital mass extending to the apex with the serpiginous enhancement in the retrobulbar fat and the recti muscles, along with the involvement of the fissures and the cavernous sinus. So as per the revised criteria, the child had capillary spots, plexiform neurofibroma, and sphenoid dysplasia, hence was diagnosed with neurofibromatosis 1, also confirmed on genetic testing. So now such cases are very difficult to treat because of the age, extensive disease, ocular complications, and the challenging surgery, because there's a huge risk of bleeding and also higher chances of regrowth. So after detailed discussion with the pediatric hemato-oncologist, we finally had a ray of hope in the form of a targeted therapy called MEK inhibitors, and the child was started on oral trametinib, 0.5 milligram once a day during the weekdays and 0.25 milligram once a day during the weekends, along with anti-glaucoma drugs, which was topical. Close follow-up was done monthly for the first 3 months, followed by 3 monthly and then 6 monthly. During this time, we did the bloods and ocular examination. Annual checkups were done in the form of ultrasound abdomen and growth plotting. Within first 3 months of starting the treatment, there was a significant improvement in proptosis and stabilization of disease, and the child was able to close the eyes. At 8 months, there was further improvement, and the quality of life of the child improved. There was reduction in refractive error, the IOP stabilized, and there was marked difference in the cup is to disc ratio now. As we can see, it is 0.2:1. The imaging showed reduced orbital mass in proptosis and less enhancement of the orbital tissues, and the volumetric analysis showed 32% reduction in the load of the mass. Child did develop skin rashes 4 months after initiation of the therapy, but was successfully treated with oral and topical steroids along with discontinuation of drug, which was restarted after 2 weeks, and the child tolerated the full dose. So, MEK inhibitors like trametinib represent a promising option for managing pediatric orbital neurofibromatosis, offering a non-invasive approach to control the tumor growth and mitigate associated symptoms. Coming to the discussion, we all know that NF1 is a common autosomal dominant disease with 1 in 3,000 people being affected worldwide, and plexiform neurofibromas are affecting 25 to 50% of NF1 patients, and the orbital cases are affecting 10% of the children. Now, the problem with this orbital PNF is that it has a rapid growth, which causes a lot of facial disfigurement, causes visual problems, and early intervention is a must. But the complete surgical resection is not an option, as we know, and partial defulking offers cosmetically unacceptable results, and the regrowth is very common. Now, we must understand that NF1 is basically caused because of mutation in the NF1 tumor suppressor gene, and once this gene is affected, the product of this gene, that is neurofibromin, becomes non-functional. So once this is non-functional, the RAF pathway is not inhibited, so there is excessive cell growth. So we are looking for these novel therapeutic options which is going to inhibit this pathway so that the cell growth is controlled. In a lot of NF1 people worldwide, trametinib has actually helped in tumor growth and also in reducing the progression of the disfigurement. In fact, first drug of this category was selumetinib, but it is quite costly and only available in tablet form, so we cannot prescribe it in younger children. This is one of the patients where we have actually started selumetinib, and we are still waiting for the results. But we need larger follow-ups and larger sample size as well. Thank you.
Thank you. So, do you think the cupping has reduced due to this, or the timolol you used along with that?
We used it, but also there was 32% reduction in the tumor load, so that apical crowding was also significantly reduced, so that pressure effect had gone. So it was probably a secondary glaucoma that was developing in the child. So I think both the things, they helped. So timolol helped during the acute phase to control the pressure, and I think even the disease load reduced. That also is
Do you
affecting
think the timolol has an apoptotic effect on the tissue, because we use it for capillary hemangioma as well?
That's a very good question, ma'am. Thank you. I had that thought. But yes, it does have effect on capillary hemangioma, but we haven't studied the effect of timolol on the neurofibroma tissues. We still have to do that.
Thank you.
Thank you.
Next is Dr. Vivekanand.
So, very good evening to judges and the delegates here. So, basically, I am going to present this paper titled as The Clinico-Demographic Characteristics of Mobius Syndrome. It is a retrospective study from tertiary eye care centers of India. I do not have any financial disclosure. So, if you look at the MBS, it is a very rare congenital disorder that is characterized by symmetrical or the asymmetrical non-progressive seventh and also the sixth nerve palsy. MBS is also seen in association with various systemic anomalies, including the cranial nerve palsies like orofacial dysmorphism, limb or axial or musculoskeletal malformations. It is a very rare disorder which was first described more extensively by Dr. Mobius in 1888. Rare disease entity in terms like one of every 50,000 live births. So if you look at how to diagnose the MBS, so there are two criteria. One is updated minimum diagnostic criteria, which was used up to till 2007. Later on, McKinnon et al. They have suggested the expansion of this, where they have excluded patients with lack of the full vertical movements. So the aim of our study was to describe the ophthalmological features and investigate whether they are specific or unique to Indian population, and compare the clinical characteristic with the reports from different geographical areas and ethnicity previously published in the literature. So it was a retrospective design where the data was collected from 2002 to 2022. So it's a 20-year data where we found there were only 21 patients. So you can understand that how rare the MBS is. So females were predominant, and the mean age at presentation was almost 9 years. And most of the patients, they had the bilateral 7th and 6th nerve palsy, which is more common, and almost 100% had both these nerve involvement. The commonest presentation was inability to move the eye since birth, and also second common was inward deviation of the eyes since birth. If you look at the perinatal or the birth history, we found that delayed development was the most common presentation, followed by the low birth weight, and then later neonatal jaundice. If you look at the ocular features, I think lagophthalmos, then the abduction limitation, which is more characteristic, although obvious. They had a limited patients with adduction limitation. Anterior segment had presentation in terms of amblyopia and exposure keratopathy. If you look at the systemic features, I think if you see the Western data, the expressionless faces, mask-like faces was the commonest presentation, followed by facial dysmorphism. And on imaging, the thinning of the corpus callosum, that was the most common radiological finding. So with this, the female preponderance, which is very much similar to reported by Kata et al., and the mean age at first presentation was very much delayed in our population, although it was similar reported by the again Kata et al. 100% of our cohort, they had a 6th as well as 7th nerve involvement, very similar to a report which, when I was there in Boston Children's, I had worked on the FBS, so we had found a very similar presentation. Adduction limitation in MBS is less common in Indian patients compared to rest of the world. There are several limitations, being the retrospective study design, inconsistency in documentations, and MBS is quite rare and thus difficult to get a large sample size. So if you compare with the motility pattern and commonest presentation, by convention, esotropia is the commonest presentation. However, exotropia and orthotropia can be presented. In our population, we found that orthotropic presentation is rare compared to, if you see the Goldmeads and the Miller and Cronenberg et al. And the limitation of adduction is less common in our population. So with this, I would like to conclude that the findings support and provides valuable insights into the clinical spectrum of MBS in Indian cohort. Ocular and systemic involvement is heterogeneous, with the most common type of strabismus being esotropia, followed by orthotropia, and adduction limitation is less common. Expressionless faces, lagophthalmos, and thinning of corpus callosum, they are characteristic features of MBS. So the future studies probably would be to collaborate with the multiple centers, being the rarity of the disease, and come up with larger data of the MBS to look at the clinical features. And if the people have operated the MBS patients for sixth nerve palsy, that also we can project later on as a surgical outcomes of patients in MBS. Thank you very much.
Thank you. So you said there are some corneal exposure and ulcer, did you say?
Yes, exposure keratopathy. There were, yeah.
So did all of them have dacryocystitis along with the
Dacryocystitis, the work which I did, the MBS is commonly associated with lacrimal dysmorphism. However, in our series, if you see CNLDO, that was seen in 2 patients, where it is accounting for almost 9.5%. Yeah.
Thank you.
Thank you.
For this session. So there will be
The winner from the other group,
the
previous
session 1.
Session 1 is Dr. Manu Sharma, who will present now.
So both Pediatric 1 and Pediatric 2 both are from PGI. You can start.
I'm feeling very fortunate to present here. Display. Manu Sharma. Good evening, everyone. My topic is immediate sequential bilateral vitreoretinal surgery for management of retinopathy of prematurity. ISBBS is defined as vitreoretinal surgery in eyes during the same anesthesia session. So it is an enormous need in the era of more advancement in neonatal care, where more of surviving premature babies coming and more is the incidence of retinopathy of prematurity. Although there is more awareness about the ROP and its sequelae, still there are many ROP cases coming to us in the advanced stage of ROP when it is not manageable with lasers and anti-VEGF alone. So here comes the role of vitrectomy. So why bilateral simultaneous? Because disease is bilateral symmetrical and it is rapidly progressive disease. Delaying the treatment even a week can lead to poor outcome. Babies are sick, premature, risk of anesthesia, but the risk of re-anesthesia for second eye surgery in the short span of time is undesirable. Also, the pediatric VR surgeons are not available everywhere and there are financial challenges also. So a single session surgery for both eyes can address all these issues with good visual outcome. So this is the baby, came to us with bilateral, symmetrical, advanced ROP. So what you will do? If you will operate the one eye in one session, then if the surgery anesthesia team doesn't clear him for other surgery, then the other eye will go blind in that short span of time. So although there are risks like general anesthesia and endophthalmitis, but still the risk of dying with a second anesthesia session is 10 lakh times more than the bilateral endophthalmitis. So our purpose is to study the efficacy, safety, anatomical outcome of bilateral sequential vitreoretinal surgery in advanced ROP. It's a retrospective interventional study conducted in tertiary care center. We include the advanced ROP cases and exclude stage 5B and 5C, electronic medical record system of the hospital to use to procure the data, and follow us for 3 months. And after doing EUA and the one eye surgery, the surgeon re-scrub, re-gown, re-glove, and re-prepare the other eye, re-drape the other eye, and the second eye is treated entirely as a second patient. Even the new set of instruments, even the vitrectomy pack is used as a new pack for the other eye. And the 2 sets of post-operative eye drops were given. And the experienced anesthesia team and the OT staff is our backbone. So 55 eyes of 28 babies with birth weight of 1,188 gram with mean gestational age of 30 weeks were included. 16 eyes had stage 4A, 36 eyes had stage B, and 2 eyes had stage 5A. Lens sparing vitrectomy was done in 50 eyes and the lensectomy vitrectomy in 5 eyes. Laser photocoagulation was done in all eyes except stage 5 and preoperative ranibizumab given in 21 eyes. Only 2 babies has anesthesia-related complications. One baby was shifted to neonatal emergency, and because there was inability to maintain the saturation, and the other eye surgery was abandoned. And the one eye had apnea post bilateral surgery, and he was kept under monitoring and recovered. No endophthalmitis was noted in any eye except hypotonic choroidals and loose blood. We achieved the anatomical success in 70% of eyes. This is the preoperative photographs and this is the postoperative anatomical success. Here is the another one. And to conclude, IBSB is the safe, feasible option with definitive advantages under good anesthetic care when the disease is bilateral, symmetrical, rapidly progressive, and the repeat anesthesia is a problem. So well-informed consent mentioning the risk of anesthesia and the bilateral endophthalmitis must be taken to avoid medico-legal consequences. So here's the patient which I have shown you at the beginning of the presentation with a bilateral symmetrical and advanced disease. This is the one-year follow-up of this patient having good anatomical outcome. And here you can see this patient can see. So this is the happy ending for this patient where we operated the patient with bilateral symmetrical disease and he achieved a good anatomical outcome with the timely surgical management. Thank you.
Dr. Manju, you want to ask some question?
Nothing really, well presented, so that's good.
Thank you.
Dr. Abhijit? Ma'am, I have assessed in the previous session.